I'd like to introduce Dr. John Davis, MD and fellow of the American College of Surgeon. He's a professor of Department of Urology, Division of Surgery, the University of Texas, MD Anderson, and also director of Urosurgical Prostate Program, also at the MD Anderson. And Dr. Davis also is a safety and quality insurance officer and oversees the safety and quality of cases performed at MD Anderson. Hi, John, and thank you for having this interview. I'd like to start with the first question that a lot of people have in mind, since you are in a very important international cancer center. What are the guidelines and recommendations that you are following, and is your institution proceeded with elective cases and surgeries in your department, and particularly in uro-oncology?
Thanks for the question, Fernando. This has, of course, been a question of debate and is a little bit attending specific. We've probably, as a group, put more emphasis on sort of large renal tumors and high-grade bladder cancer, and we are still open for elective cases, which is not the case. I certainly have spoken to colleagues around the country who are just completely shut down, depending on their actual COVID virus census. But we are leaving some of our high-grade prostate cancers on the schedule. There's a bit of a debate with the literature about whether or not a 3-month wait or a 6-month wait is appropriate. And some of the patients are actually on clinical trials where there's drug therapy involved in a sort of a clinical window of time.
John, for patients with intermediate to a more aggressive prostate cancer, would you consider hormonal treatment to kind of bridge between now and the procedure that can be planned after the crisis with COVID-19?
Well, we do this frequently on clinical trials, so we're not really particularly worried about the surgery being harder. It may be a little bit harder, and definitely there are patients out there who feel more comfortable that there's active treatment underway, and certainly if they were having a radiotherapy plan, they'd be having hormonal therapy of varying lengths. So I think if there's excessive delay, some patients are requesting it. And I've had a handful of out-of-state patients actually ask to sort of start over and inquire about whether or not they should switch to radiation if, you know, if access to the operating room is going to be difficult for the hard to measure future. So we have done it selectively, but in general, if we get to them in under 3-4 months, maybe you can push it a little bit depending how much volume you have, then we've gone without it.
Okay. So I was wondering if we could, you know, just have your, I don't know, your perspective, or how do you see this crisis really? I don't know where MD Anderson, what are the guidelines, first of all, that you're following? Because are you doing any elective surgeries?
Currently, we do have elective surgery, and what we've done is set up a committee that's composed of a lot of the quality and safety officers from all the surgical divisions, and then the department chairs. And so what we've done as a group is look at any new requests for posting that can't wait until after middle of May, and decide whether or not, you know, those cases are appropriate. We're increasingly looking at existing postings to be sure, you know, we're conserving our resources. And the main resources of concern are ICU stay and blood. You know, there's less blood transfusion donors going on. So if cases that are high on resources, especially if they have a very minimal, gain, like hero type surgeries actually been discussed as a phenomenon, then the committee will give guidance. Now that's a nice thing. We have an ethicist on the panel, and then we provide documentation in the chart whether or not a case is approved or not approved. So we, in the urology end of it, we've emphasized large renal tumors, especially renal thrombus cases, and then of course invasive bladder cancer, especially if they're coming off of a chemotherapy protocol and have kind of a tight window of time. So that's we've probably reduced the OR to about 25% of capacity, so that we can keep room for COVID admissions and/or intensive care unit resources. Texas is a little bit behind the rest of the country, so we're not totally shut down, but we're trying to defer things so that we have those resources.
So for the practicing urologist that is not in a tertiary care facility, a community hospital, what are your recommendations? Because we got to think about the providers, the capacity, the PPE, and all those things, but also the patient. What are your recommendations in terms of how they have to proceed with prostate cancer patients?
Well, I think one of the themes that I've observed in our institution is that everything changes week by week. So obviously PP is a concern, and the N95 masks are certainly being very carefully allocated to cases where there's an open airway, like head and neck surgery, and then anesthesia is allowed to use them during intubation, extubation. But on the other hand, I think a lot of the generic PPAs improved. So starting today at our hospital, everyone who walks in the door is going to get an ear loop mask, patients and employees. So that's an improvement over a few weeks ago. We're being judicious with the resident training, so we don't double scrub or have additional observers in the operating room. So I think the PP seems to be improving slightly, although the N95s are lagging. But more directly to your question, obviously the favorable intermediate and probably even the unfavorable intermediate are the easier ones that likely could be easily treated within a 6-month window. Favorable intermediate, probably any time in a year. Obviously, patients are still concerned about the risk of spreading, and this is tricky because they don't always understand the differences between stage migration from a delay versus actual biochemical recurrence. And that's kind of what's not terribly strong in the literature is how much influence there is on actual recurrence. I mean, you can have extra prostatic extension the day you had your biopsy, but the timing of surgery is not always known to be as critical compared to, other, solid tumors that are more quickly biological. So rule of thumb, I'm very comfortable with intermediate risk and below within a 6-month window, high grade within a 3-month window. And then outside of that, you have to kind of individualize the patient's, details and expectations. I think there was another question that you hinted on that I've been thinking a lot about, which is obviously just risk to the operating team. And we've had a lot of internal discussions and analysis about, smoke plume from cautery devices and just circulating CO2. And so we worry about an undiagnosed patient having surgery and then, infecting other people on the OR team. In addition, there's a handful of cases from, both West and East Coast where people have had elective surgery and then gotten COVID and had very horrible outcomes, including some fatalities. So I think what's missing that I hope will come soon is if someone's having if you got to do elective surgery and we get to that point, I've been telling patients to self-quarantine for 2 weeks to minimize their risk. And then the second part, I'd really like to get to a point where we can routinely test patients who are going for elective surgery. We know that some of these tests have a false negative rate of around 20%. I think most of that's probably in the first week, when the viral load is less. So I hope that you can test someone with a rapid turnaround, say on day 12 or so, and then surgery on day 14, something like that. Safety for them as well as the operating room team.
I think you make a great point, and also probably consider spinal anesthesia versus general anesthesia. Do you think this is feasible for robotic surgery?
Well, that's an interesting one. I've never thought you could do laparoscopy without insufflating the abdomen to some degree. But I mean, there was certainly we used to do that open. But then you get into skill sets and who's comfortable doing certain operations open versus laparoscopy.
That's a great overview, and thank you very much, Dr. Davis.
All right. Well, everybody stay safe, and thank you.